The patient needs to have continuous cardiac monitoring in place and echo guidance for the procedure. This can be performed at the bedside within critical care areas, supported by advanced life support staff. The risk of further clinical deterioration is high, and prior to the procedure, you should ensure all resuscitation equipment is in immediate proximity, and the patient should have defibrillator pads on. Depending on the patient's clinical condition, you may need to alert the rapid response team if deterioration occurs. Refer to the equipment list in the pericardiocentesis procedure for details of all equipment required. To prepare the patient for the procedure, clip chest hair if required, and ensure patent IV access and IV fluids are available. Continuous cardiac monitoring is required for all patients, ensuring the ECG dots are placed away from the sterile field. Pre-procedure ECG and chest X-rays are required and need to be reviewed by a medical officer. The patient's blood results also need to be reviewed, as altered clotting times may increase risk. Position the patient at a 30 to 45 degree angle. This encourages fluid to drain into the lower portion of the pericardial space. Organise oxygen and complete a full set of observations. Attend hand hygiene and set up procedure trolley. All staff involved in the procedure must agree and understand their procedural role. All clinicians involved must attend timeout and complete the Level 3 Clinical Procedure Safety Checklist. The only exception to this if it is a life-threatening emergency situation. The proceduralist will mark the proposed puncture site on the chest wall. During the procedure, the nurse's role is to assist the medical officer with the procedure and continuously monitor the patient throughout the procedure. Another nursing role is to collect specimens and attach the drain. Observe the patient's ST segments and patient's rhythm for alterations that may indicate myocardial damage or irritation by the needle, and monitor the patient for pain. Observe and record the drainage volume. As a general rule, the medical officer may advise to limit initial drainage to half the estimated effusion volume, or 300 millilitres, whichever is less, to avoid rebound right-sided failure, then 100 to 200 millilitres per hour for the following hours. Continue to monitor the patient's vital signs post-procedure, decreasing the frequency as the patient's condition stabilises.